I think it's important, at least for our listeners on Ontario, that anyone can access a PSMA PET scan in the community now. It doesn't have to go to those centers with the registry. It is it's a gallium-68 scan, but it's paid for by the government. And the wait times are very reasonable. I think they've actually normalized pretty much in the community and
generally
in our centers. It used to be many months, and I think it's 2 to 4 weeks now. And I think that's a reasonable way. In terms of what I do about it, we can talk about that a little bit. So again, so the approach, so let's go back. I always like to go back from an evidence point of view. So what is our standard? So the way I start the conversation with a patient is the standard of care is either intermittent androgen blockade. So if their scans are negative, conventionally, then they're not metastatic. And the standard of care in that setting is intermittent androgen blockade based on PR7, which was the We Need a Crook and Lori Klotz study. Then the question is, what is the effect of being able to identify, or what is the value of identifying patients with novel imaging that are conventionally negative? Probably it's an in-between state. So if you look at the EMBARK study, for example, if you take EMBARK patients and you do PSMA PET scans, it was a Belgian study, I think. You probably know it, Chris. About 50% of patients had metastatic disease, 85% of patients had some disease identifiable on PET scan. And so these are probably patients in the EMBARK study where systemic intensification makes sense.